So thank you so much, sir. So myself, Dr. Rakesh Andi, consultant here. So in the next few minutes, I'm going to take you regarding the advanced hemodynamic monitoring. So I'm not going to completely cover the spectrum of invasive hemodynamic monitoring. So I'm going to cover only 3 topics here. So one is your picco, one is your lidco, and then your flotrac. So these are the 3 topics which I'm going to cover here. So basically what is meant by hemodynamic monitoring, as you all know by this point of time, it's like monitoring the physiological variables over time. So just monitoring per se will not help the improvement of the patient. Okay, you need to do a timely intervention and you need to do a right intervention. So to do this, you need to understand what are the basic physiology of the patient, you need to understand the physiology of the monitor, and you need to correlate clinically both of them. In that point only, then only you can do a timely right intervention that helps for the outcome of the patient. So these are the 3 things which I'm going to cover: picco, lidco, and then flotrac. So next, picco, I'm going to cover what is the method here, what are the principles involved, so what are the various variables which you are going to cover. So indications is same for any type of hemodynamic monitoring. So indications is like shock, is it a septic shock or a cardiogenic shock or a hypovolemic shock, sepsis, trauma patients, and then pulmonary edema patients. So you don't know what's the reason for the pulmonary edema. In those situations also you can go for hemodynamic monitoring. Acute lung injury, burns patient for fluid resuscitations, and any condition that requires assessment of hemodynamic or volumetric functions. So these indications stand still for any type of hemodynamic monitoring. So let us see what are the principles involved in our picco. So picco uses combination of 2 techniques here. So one is advanced hemodynamic monitoring, which can be done by means of your transpermanent dermodilution, and volumetric monitoring, which can be done by your pulse contour analysis. So these are the basic 2 principles involved here. One is dermodilution method, and pulse contour analysis. So all types of hemodynamic monitors advanced, they have a combination of these 2 techniques. They might change a little bit. If you are using a lithium dilation technique, you call it as lidco. If you are using a dermodilation technique, you call it as a transpulmonary dilation. You can use a central line or you can use a pulmonary artery cath also. So what you see, so next slides I'll tell you about what is meant by transpulmonary dermodilution. So you need to insert 2 catheters specifically for your transpulmonary dermodilution. One is your central line, which should be having a thermistor port, and then an arterial line also, which is specific for the picco. It comes with a you can see this one. It comes with a temperature sensor here. So these 2 things are mandatory to have a picco. So this is how the picco system looks on a real-time patient actually. So you need to have a patient here, a central line with the thermistor which I am speaking here. So this is connected to the monitor which senses the temperature of the saline which you are giving here, and then it goes on to the right side of the heart and then comes to the left side of the heart, and you need to place a arterial line in the femoral system, and it also comes with a temperature sensor which got an interface and then connected to the same monitor. So this monitor is the one which differentiates the temperature between the injectate and the blood. So this is the main monitor, and then there is a pressure transducer system which is routine for your all invasive hemodynamic monitoring. So transpulmonary dermodilution, you are supposed to inject a cold saline through a central venous catheter, and the amount of cold saline, temperature of the cold saline should be entered first into the monitor. So monitor should be given an order that this amount of volume I am injecting and this amount of cold saline I am injecting. So that mixes with the blood volume and passes to the right side as I told it earlier. So after passing the left heart, the arterial line measures the drop in the temperature. Because you are giving a cold saline here, what happens to your blood temperature? There is a drop in the temperature that is measured by the arterial end of the catheter. And then from that drop in temperature, it will extrapolate a curve that is called as a thermodilution curve. And based on applying some equation called Stewart-Hamilton equation on the thermodilution curve, it will give us some cardiac output. That is a routine hemodynamic monitoring. So this is the thermodilation curve I am talking about. So this is the base of the basal temperature of the blood here. Once you inject the cold saline, the drop in the temperature has been sensed by the arterial catheter, and once the drop in the temperature is completed, it again comes back to normal. So this is actually one cardiac cycle, if you say that. But actually what happens here, with one cardiac cycle, your temperature will never return to normal. So it will have a gradual slope here. By applying some physics here, and then we just try to extrapolate the curve, and then it will calculate the cardiac output. So that equation is called as Stewart-Hamilton's equation. Is it visible? Yeah. The Stewart-Hamilton equation. It is given by the formula temperature difference into volume of the injectate that is given to the patient with a constant. This constant is actually derived based upon the specific gravity of the blood and the amount of volume that you are injecting, and then divided by the area under the curve. So this is the area under the curve, and this one comes your temperature difference into volume into constant. So it can clearly see that area under the curve is inversely proportional to the cardiac output. So if the area under the curve is high, cardiac output is low. If the curve area under the curve is low, the cardiac output is high. Clear? So what are the common artifacts you see? So generally you get this type of thermodilution curve, but there are some artifacts which we generally see while monitoring these thermodilution curves. So this one will show the area under the curve is very high, or the time taken for the temperature to fall is very high. That means the cardiac output is low. You can see here the time taken by the temperature to come down to normal is very less, so it is a high cardiac output curve. Clear? Sometimes there is a poor injection technique where this 20 ml of saline boluses should be given at a time. It should not be supposed to be as a intermittent techniques. It should be given as a particular bolus. If you are giving in a poor injection technique, this type of curves will come, in which the monitor will not accept. This is the respiratory artifact which we generally see. So what are the various other difficulties generally we face while using a thermodilution curves? It might be your tricuspid regurgitation, or it might be your pulmonary regurgitations, or intracardiac shunts. Whenever there is a structural heart disease, make sure that your thermodilution curves or your cardiac output monitors are not perfectly accurate. So what happens? Let us see. So what happens if there is a tricuspid regurgitation or a pulmonary regurgitation? The amount of saline or the dye which you are giving on the right side of the heart, what happens? It will get diluted. It will get more amount of blood comes to the right side of the heart, so it will get diluted, and it will take a long temperature decay times. That means the temperature on the x-axis will be prolonged. That means what happens? It indicates an erroneously low cardiac output. Clear? Whenever you have shunts, what happens to the shunts? If there is a right to left shunt, whatever the amount of dye which are given on the right side of the heart, it bypasses the right ventricular system, lung, and then directly goes into the left side of the heart, and then it's sensed by the sensor. In those situations, what happens? It's time taken by the temperature to drop is very less here, so erroneously it will record a high cardiac output. Again, the left to right shunt is reversed for that. Amount of drug which you are giving is diluted again, the time taken will be long, and then the cardiac output is erroneously showed as a less. So am I clear till now? So these are the various difficulties which we face when you have structural heart problems. So keep these things in mind. Don't just go by the values. So one more thing, as I'm telling earlier, this is the actual thermodilution curve which happens. There is a recirculation that happens after one cardiac cycle. But we try to extrapolate that curve towards the x-axis, making it as a once complete cardiac cycle. So based on these values, these monitors will give us some parameters like intrathoracic thermal volume, intrathoracic pulmonary volumes, these parameters. So these are the main things you need to know. One is the mean transit time. The another one is called as a downward slope time. So mean transit time is defined as the amount of the indicator, half of the indicator should be passing the injection of the artery. So the amount of indicator, the amount of volume which is given to the patient, if the half amount of them has been completely passing to the arterial end, we call it as a mean transit time. The time taken for it to pass the arterial end is called as a mean transit time. And the slope, the rate of coming down, that is called as slope. That is called exponential time of the downward slope curve. So once these values has been taken by the monitor, so it will give us these different parameters. So it can be calculated by using different things. It can be clearly seen here. The total amount of blood volume which is present in the thorax is called as intrathoracic thermal volume. It includes RA, RV, blood volume, extravascular lung volume, and LA and LV. So it is given by the formula cardiac output into the mean transit time. The time taken by the diluent multiplied with your cardiac output gives you the intrathoracic thermal volume. The next one is pulmonary thermal volume. So amount of blood which is present only in the lungs, whether it is an extravascular lung water or whether it is a pulmonary blood volume, both together it comes your pulmonary thermal volume. It can be given by the formula cardiac output into downward slope time. Okay, and the next one, by differentiating or subtracting these two things, you can get global end diastolic volume, that is called GEDV. Okay, and then if you want to multiply the GEDV with 1.25, because the thermal volume which is present in the lungs is almost 1.25 times the global end diastolic volume, we'll get intrathoracic blood volume. If you say thermal volume, it includes your extravascular lung water. If you say blood volume, it does not include extravascular lung water. So by calculating thermal volume and blood volume, the difference simply gives you how much amount of water is present in the extravascular space of the lung. So you can treat the pulmonary edemas here. So this is how the monitor derives all the values, and based on these values you are going to treat your particular patient, right? So So till now I discussed about the thermodilution curve. What are the variables here? Next is your pulse contour analysis, which is common for any type of arterial blood pressure monitoring. So this pulse contour analysis, what it do? It gives a continuous cardiac output based on the stroke volume calculation. So it calculates the area under the curve of your arterial line, which is particularly restricted to your systole. So systolic part of the curve, area under the curve, is called as stroke volume. So when it is multiplied your heart rate, it gets your cardiac output. This is how this pulse contour analysis will calculate your cardiac output. And then there is something called as, there is a formula here, calibration factor. So this calibration factor, why are you doing this actually thermodilution runs, and why are you doing these calibrations once in a while? Because you need to derive a calibration factor from your thermodilution curve. Once you derive the calibration factor, heart rate is already known to the machine. So this picco machine will then display your cardiac output based on this complex formula. Okay, so I'm not going to details of this formula, but you need to have your calibration factor, you need to have your heart rate, you need to have the area under the curve, which is your stroke volume, you need to know the chaotic compliance, which can also be derived from the curve. The rate of downward slope time gives your aortic compliance and shape of the curve. So based on all these factors, this picco will give you an exact cardiac output. Clear? So, but it causes, it has so many prerequisites actually. The patient should be 100% mechanically ventilated. No spontaneous breaths is allowed in these patients if you want to calculate exact cardiac output. And the tidal volume for this patient should be around 6 to 8 ml per kg. Patient should not have any arrhythmias, and you're not supposed to allow any spontaneous breaths while calculating the picco. So this is one thing which pulse contour analysis also will do, stroke volume variation and pulse pressure variation. If you so many of us will monitor these things. The arterial pressure will change along with your respirations. So this is the inspiration and this is the expression that's happening here. So these monitors will display one more variable called as stroke volume variation given by this formula. The stroke volume maximum minus the minimum divided by your mean. Okay, that gives your stroke volume variation, which should be less than 10%. If it is more than 10%, the patient is hemodynamically unstable or hypovolemic. So taking these three values from the temperature and time graph, like cardiac output, MTT and DSD, picco estimates your cardiac output, picco estimates your preload, which is nothing but your intrathoracic blood volume, and degree of pulmonary edema, which is nothing but your extravascular lung water index. The index and volumes are same. If you divide by your body weight, body surface area, you'll get an index here. So both the values are nearly the same. So these are the various thermodilution parameters which are supposed to get while using picco: the cardiac output, cardiac index. Preload, it might be a global end-diastolic index or intrathoracic blood volume index. Pulmonary edema, as I said, it's an extra lung water index or pulmonary vascular permeability index. There is one more called as permeability index of the pulmonary vasculature, where the extravascular lung volume divided by your pulmonary blood volume. Contractility of the heart, which is given by means of your cardiac function index, and then global ejection fraction. Coming to pulse contour parameters, these pulse contour parameters will give you about the flow, pulse contour based cardiac output, arterial blood pressure, heart rate, stroke volume, which is area under the systolic part of the curve. Volume responsiveness is assessed by means of either your stroke volume variation or your pulse pressure variation. The same thing. If you take the volume, it's called as stroke volume variation. If you take the pressure in the graph, it is called as pulse pressure variation. Or you can have a systolic pressure variation also. But you need to know the normal values. Normal pulse pressure variation should be less than 30. Normal systolic pressure variation should be less than 10 millimeters of mercury. So afterload is again given by your SVRI, systemic vascular resistance index, contractility and index of left ventricle. So these are various parameters which can be given by pulse contour parameters. So combine these two parameters, you need to adjust for the patient's clinical status and then decide in the algorithm what you are going to do for this particular patient. See, the goal of hemodynamic monitoring is whether you want to add a drug or whether you want to delete a drug, whether you want to load the patient with fluids or whether you want to dehydrate him by giving some diuretics also. So if you can see this flow chart, first thing which you should monitor your is cardiac index. If the cardiac index is low, next step is monitoring your intrathoracic blood volume index. So if it is also low, and then it's the extravascular lung volume which is also low, that means the patient is hypovolemic. So in these conditions, you need to suppose you give a volume bolus to the patient and then observe for the responses. And the targets is again the same in the reverse order it was written. So if you are able to achieve the targets, yes, you are doing a good thing here. Right? If the cardiac index is low, volume is low, and then pulmonary edema is high, in these situations you need to give volume very cautiously, and then you need to add a catecholamines. So and then assess for the response. Okay. Coming here, if the cardiac index is low with the volume is high, again pulmonary edema. See the pulmonary edema. Whatever the situation, if the volume is very high, in both the situations you need to give catecholamines. But only if there is pulmonary edema, extravascular lung water is very high, in those situations you need to have a diuretic here. and then assess the response. So but this is actually a temporary measure. What they suggest is give a diuretic and see whether the response is coming in terms of your targets here. So this is one part of the curve where your cardiac index is less. If the cardiac index is high with a volume normal or low here, if there is volume less in the lungs, I think again the fluids here. If the cardiac index is high with a volume less in the lungs and then extravascular lung volume is very high, again the volume, but it's a temporary measure, you can also wait here. If the cardiac index is good, intrathoracic blood volume is good, with a pulmonary edema is less than 10, extravascular lung volume is less than 10, you can wait here. This is a normal patient actually. If that is also high, you can add some diuretics here. You can do some volume contraction. Always try to see the responses here. So whether you are doing correct for the patient or not. So this flowchart everyone needs to know. So by doing this flowchart, you can only do this, small changes in the patient. So right till now, what you have learned about how the picco system works, what are the basic principles involved, how it is used to guide for the patient, what are the various parameters like preload, afterload, cardiac output, and then what are extravascular lung water indexes and intrathoracic blood volume, these things are done. So last 4 points you need to see on the machine itself. So what should be the arterial pressure port labeled? So you have a workshop in the evening, so you can learn from there. What are the determinants for accuracy of calculations? But I said the prerequisites again here. What are the recommended values for saline and what are the recommended temperatures? Again, you can go and see in the workshop. So CRRT and then patients on other hemodynamic monitors like IABP or ECMO. So monitoring your cardiac output is very difficult here. So you can have this talk in the evening session. Clear? So I'll move on to next topic, lidco. As I said, indications are almost common for lidco, picco or any hemodynamic monitoring. You need to know the contraindications here where we use a dye dilution technique. So any psychiatric patients who are on lithium salts, it overestimates your cardiac output. And patients less than 40 kgs, its accuracy has not been defined. First trimester of pregnancy because of the fatal toxicity. So one more condition called peripheral vascular diseases where your pulse contour waveform will be completely destroyed and then the software unable to calculate your pulse contour waveform in a patients who are having a peripheral vascular disease and patients undergoing treatments with intra-aortic balloon pumps. And one more thing is some muscle relaxant. So if you are using a continuous muscle relaxant for your ARDS patients or you are using a bolus dose of muscle relaxants, these muscle relaxants are going to interfere with your lithium dye concentrations which is sensed by the sensor. So I am going to show you the sensor, how it works. In those situations, instead of doing intermittent techniques, bolus techniques of administration has to be adopted. Okay? And shunts. Yeah, any shunts, your cardiac output monitors tend to overestimate or underestimate. You should know the physiology behind that. So calibration, one more advantage of this system is no need of calibration. You need to calibrate the system for only 24 hours. Sorry. It comes with a triple fold accessory pack. So the triple fold accessory pack is nothing but it contains 3 circuits. One is spark and ride circuit. Another one is an arterial pressure thermistor will be there on the arterial side. Another thing is a lithium sensor. It comes with a triple fold pack. And lithium chloride ampules will be shared. Sensor should be stored away from the direct sunlight. And these wicks, I will show you in the next slide. So these sensor wicks needs to be sufficiently primed with the 0.9% NS. And sensor cable ends should be always kept dry. And one more biggest advantage of using lidco is no need of your central line. You can use the peripheral line for injecting the dye and measure the concentration on the arterial end. So in the thermodilation curves, you are measuring the temperature. And in the lidco curves, you are measuring the lithium dye concentration on the arterial end. Clear? So this is how the system will be there. So either the central line or the peripheral line, you need to inject a particular amount of lithium chloride solution with a particular concentration known. Okay. After injecting it, the other end will have an arterial transducer. So this is the arterial transducer and this is the sensor which was enlarged here. It comes with a wick inside. So this wick is going to measure your lithium concentrations. It comes with an electrode. It goes back to the monitor. And then it comes with a display thing, and it comes with a graph. So this graph is actually lithium dye dilution graph. The other one which you see is thermal dilution graph. And by taking the values, the same thing, the mean transit time, downward slope time is almost the same, the principle is same. And then by using this graph, it will give your cardiac output values. Okay? So I'll show you a small video here. So he is taking that lithium solution from the lithium ampule actually. So you have to suppose to take 3 ml of the solution which contains 0.3 millimoles of lithium here. So he is going to inject that into that park and ride tube. This tube will not be complete. The volume of this tube is around 2 cc. So he's just loading the tube with this lithium solution and keeping the things ready. So once that is loaded, so he's connecting the saline flush, 20 ml of saline flush. Okay. So once that is done, so go to the arterial end. So the arterial end comes out with the arterial cannula. So he's closing the arterial cannula. I'll stop it here. So if you can see this. So this is the bridge here. This is the lithium concentration dye, concentration measuring, that wick here says here. And there is one pump here, which comes your cardiac pulmonary bypass pump, but a smaller volume. Okay. So what you're supposed to do, so once you're given the dye in the park and ride cannula inside in the peripheral lines, what you're supposed to do. So after doing that, close the arterial system and try to flush the wick with some amount of blood. So once he opens it, so the blood comes from the arterial end and then flushes the wick here. So once that is done, he'll switch on the pump. This pump will go on running with a slower speed. You can see some head rotating here like your cardiac bypass pump. So once that is done, the machine will show that it's ready to inject, the lidco machine. Once you're ready to inject, give the flush bolus here. Okay. So once you give the flush bolus, close it, and then the machine will calibrate the lithium dye concentration graph. The same as your thermodilation, but the only thing difference is the lithium concentration here. So once that is done, once you get the graph, flush the wick here, flush the sensor here, and then open it for your pulse contour analysis. Okay, again the principle are the same. There is a thermodilution with the pulse contour analysis, here is a lithium dye dilution with the pulse contour analysis. And then again open it up for your routine arterial pressure monitor. So you'll get a graph. So if there is an error in the graph, it is always ask us to recalibrate. You have to do this technique twice or thrice in your machine so that there should not be any error difference more than 10 to 15%. Okay. Once the machine says okay, that is fine. The calibration is done for the day. You have to recalibrate it after 24 hours. So these are the, I'll show you next slide. So again it comes with some formula, I'll show it in the next slide. You always enter the sensor constant, which is 10.5, the conversion factor for lithium, and the dose of lithium is always 0.3 millimoles and 2 ml should be given. Patients who are having high body weight, you need to have 3 ml of lithium chloride and change the dose to 0.45. Remember, patients less than 40 kgs, it's a contraindication. So it is given by this formula, lithium dose into 60 divided by area of the curve into 1 minus your packed cell volume. Because lithium gets distributed only in your plasma, that 1 minus PCV has come here. If you are not having an arterial lane, one more advantage is you can use your non-invasive arterial pressure monitoring, that is continuous non-invasive arterial pressure monitor, CNAP sensor. Dr. Pankaj is talking about this sensor. Even this sensor comes with a monitor that comes connected to your finger here, that will give an arterial pressure waveform. By using that arterial pressure waveform, again the pulse contour analysis can be done. Calibrating those two things, you can have so many values. So these are the various values lidco gives to us. One is the cardiac output, the cardiac index, SVR, SVRI, stroke volume variation, and then one more thing, mixed venous oxygen saturation. Clear? The biggest advantage of using lidco is, generally if you do some fluid challenge or if you give some vasopressor, so you need to have older values recorded in your mind and then you need to see the responses. But when it comes to lidco machine, it will always display the percentage change here. So by doing the percentage change in your cardiac output and stroke volume, what are the therapy which you are giving, is it accurate for that particular patient or not, you can have an idea. Okay, coming to flotrac. So again, flotrac uses the same principles, but again in flotrac there is no need for calibrations here. The biggest advantage of flotrac is it's a continuous monitor, no calibrations is required. It again uses the same principles, but instead of using a dye, instead of using something called as dye or a lithium drug, so it has a continuous thermodilution curves, which is an inbuilt monitor, and then along with that it uses your pulse contour analysis. So these are the various variables which you can see. The pulse contour analysis is almost the same. I am not going to repeat that. So you need to have a specialized sensor. Okay, this specialized sensor connects your flotrac machine to your monitor. Okay, then only you can have the pulse contour analysis to be done. You need to have a specialized sensor and can be connected to any arterial line. It's not any system specific. You can have your switch cannulas, you can have any type of arterial lines, you can connect that, and no need of calibration. That's the biggest advantage of using a flotrac. And then it comes with a attached Vigiligo monitor. So this is the Vigiligo monitor which displays various variables, your cardiac output, stroke volume index, and then resistance index. So whatever comes the values, you need to know the flow chart so that for the interventions to be done. So these are the various parameters which it shows, as I'm mentioning here. I'm not going to repeat all these things. So you need to see, one more thing is a stroke volume variation. So if it is more than 13, yes, give a volume challenge and then see it should come less than 10. If it is less than 13, and then go for stroke volume index. If the index is normal, you need to go vasopressor. If the index is little bit low, try to increase your inotropic supports. Or if your stroke volume index is high, in these situations you need to add a diuretic. So you can get these values without any central line, without any peripheral line, by just connecting your arterial line to a flotrac. You can get this cardiac output, stroke volume, and then stroke volume variation on your basic pulse contour analysis. But if you want to get these advanced values like SVIR, index SVRI, you need to have a central line, you need to have a CEP entered to the patient or entered in the monitor. Sorry. So these are the continuous variables which you get. Simple arterial line is sufficient for that, but you have a central line in place also. You can get intermittent variables because it gets refreshed every 20 seconds. So intermittent variables again, SVR, global end-diastolic volume, extravascular lung water. So biggest is if you have a hemosphere for you. This is called as hemosphere here. That is nothing but a monitor with a display is very good here. If you have a hemosphere, it will give you the extravascular lung volume displayed in the machine itself. And the pictorial representation of your extravascular lung volume is the advantage in flotrac along with your remaining advantages. So this one is actually the volume V system, which is a full flotrac here. But you need to have a volume V sensor, same like your previous picco system. That volume V sensor is incorporated into your central line. And volume V femoral artery catheter. Again, you need to have a separate volume V femoral artery catheter connected to your flotrac system. The principle does not change, only the skeleton changes always. So this is the whole spectrum of your hemodynamic monitoring coming from invasive techniques, less invasive, non-invasive. So non-invasive has been completely covered by Pankaj. Less invasive techniques we have done about picco, lidco and your flotracs. And completely invasive technique is your pulmonary artery catheter. So pulmonary artery catheter uses only your thermodilution curves. Less invasive techniques uses thermodilution along with your pulse contour analysis. Non-invasive uses always that's a different technology that they are using it now. So this is the whole spectrum of your hemodynamic monitoring. I'd like to conclude my talk here. Thank you.